Hello everybody, it's James here, and this is the first Biome Bite. The Biome Bites are shorter podcasts hosted by me, and in Biome Bites I'm the only guest, so essentially it's just me talking to you as a listener. Today's episode will focus on something we've talked about a lot on the podcast, something called faecal microbiota transplantation, also known as FMT. You may have heard of it referred to as stool transplantation, poo transplantation, intestinal microbiota transfer, intestinal microbiome transplantation, and potentially even other things that I may not be aware of. And you've probably thought, what is that? You may have heard of it before and you want more information. So in today's Biome Bite, we're going to give an overview of FMT, also known as IMT, if you refer to it as intestinal microbiota transfer, which is my preference, and I'll get on to that in this episode. In subsequent Biome Bites relating to FMT, IMT, I'll dig deeper and talk through the latest evidence as well as how the industry is developing. So let's start with the basics of the basics. What is FMT, IMT? FMT, and I'll just refer to it now from now on in this episode as FMT, is a medical procedure in which microorganisms are moved into the intestinal tract of a recipient with the intention of preventing, treating, curing a disease or a condition. Now, where do the microbes come from? The microbes come from the stool, hence the name faecal microbiota transplantation. And that stool can either be derived from the person who's receiving the FMT, as in it's coming from themselves and going into themselves, and that's called an autologous FMT. Or it can come from a related, unrelated, healthy, some cases even unhealthy, and I'll get to that in a later episode, donor. And in this case, when it's not come from the person who's receiving the microorganisms which are derived from the stool, it's called allogeneic. And you can look up the definitions of those words, but essentially they relate to the source of the material that's been moved into someone else. We also see in the case of allogeneic, it can come from more than one donor, so it can be mixed. I've seen in the medical literature it coming from up to 7 donors in a trial in which they administered FMT to patients suffering from ulcerative colitis, a form of inflammatory bowel disease. So I think it's important to understand that it's a procedure and it's not a medicinal product in itself. What's medicinal about FMT is the microorganisms that are being administered as part of the procedure. Now, we can ask ourselves, when did FMT first originate? Who was the first person to do it? And the answer to that question is it's not actually that clear. And it's probably much older than you might think. So in 2022, we're doing FMT routinely for patients suffering from nasty infections associated with a bacterium called C. difficile, also known as C. diff. There's also been a large number of clinical trials in other disease areas like ulcerative colitis, as I just mentioned, but also irritable bowel syndrome, IBS, and patients suffering from various different types of cancer as a means of improving how they respond to cancer drugs. And that's just a very, very small segment of all the possible indications in clinical trials. So actually, the first recorded cases of FMT seem to originate back to ancient China, probably 4th or 5th century. And they prescribed this suspension of microorganisms called yellow dragon soup. In other areas of medicine, such as the veterinary world, FMT is performed reasonably routinely as a means to treat mastitis, for example, and colitis in horses and cows. And you may also be aware of the fact that some animals perform something called chorophagia, essentially the consumption of feces, as just part of being themselves. Why do they do that? I think there's lots of different theories. But what I'm trying to say is it's not totally unprecedented for mammalian species, i.e. humans, and others to essentially get microbes from other sources to potentiate or improve their health and well-being. And it might be that we've actually evolved to benefit from the consumption of microorganisms in this manner. So you might be wondering, how do the microorganisms get into the patient? How is it administered? How is it prepared? So on and so on. And I'll give a high-level overview of all of that now. And in later Biome Bites, we'll cut out sections of the whole process of finding a donor and administering the microorganisms and what happens after, cut it up and then do deeper dives into each individual area. So a donor provides a stool sample, and that donor, typically, if they're not related to the patient, would undergo a series of screening tests to make sure that they're free of disease. Now, if they're related to the patient, some people, some clinicians, whoever's providing the FMT, or at least providing the material that's used to manufacture and ultimately produce the microbes that are used in FMT, take the view that if they're related to the recipient, then there's less of a need to screen because they live together, and as a result of that, they are probably carrying the same bugs. Now, that said, the more and more we understand about FMT, the more and more we realise that donor screening is fundamental and extremely important in the context of making sure that what's being administered is safe. And even if donors are relatives now, typically they're screened in the same way as an unrelated person would be. So what does the screening involve? Well, it's trying to reduce the risk as far as practically possible of an objectionable organism, also known as a pathogen, being present within the stool donation, and reducing the risk as far as possible of the kind of global microbial community profile being pro-inflammatory or being conducive to the development of a microbiome-mediated disease. What do I mean by that? And what I mean by that is that we have observed that the microbiome changes in large numbers of patients with diseases. I'll just name a few. Multiple sclerosis, obesity, type 2 diabetes. And it might be that these changes that we've observed are actually driving the disease processes. Therefore, you probably wouldn't want to transfer microorganisms from someone suffering from type 2 diabetes into someone suffering from something else, because you might then trigger processes that could ultimately lead to type 2 diabetes, if you see what I mean. And there's no easy way of characterizing that other than making sure that the donor doesn't have type 2 diabetes. So there's a whole raft of questionnaire-based screening procedures and questions that exist to reduce the theoretical risk of the transfer of a microbiome-mediated disease through the microorganisms that are administered as part of FMT. The other elements relate to the objectionable organisms, pathogens. And what we do is we ask people if they've travelled, we ask about their sexual history, we ask if they currently have an infection or they're feeling well, fit and healthy on the day of donation, so on and so on. We also extensively screen their blood and extensively screen their stool. And you might be thinking, some of that sounds quite familiar. It sounds a little bit like blood transfusions and what I've done or what I've heard people do as they go to donate blood. And there's a lot of parallels actually between donors for FMT and donors for blood transfusion. Now, the purpose of this Biome Bite is to give a high-level overview, so I'm going to kind of stop there and not go any deeper into what kind of pathogens we look for, what kind of tests we do, how frequently do we do it. That will form the basis of a much more detailed discussion at a later date. So we've tried to make sure that the microorganisms are safe. We've talked about it coming from a patient in the form of an autologous procedure, or a donor or multiple donors in the form of an allogeneic procedure. The benefits of an allogeneic procedure, for example, over an autologous, is that you might be trying to change the microbiome in a particular kind of way that possibly couldn't be achieved if you're just giving yourself your own microorganisms back. Now, how are the microorganisms manufactured? Do they just sort of take a stool sample and do one or two things and then trying to get it into the patient, or do we do a large number of different manipulations and processes? So historically, we had rather unsophisticated, quite crude methodology. And it was really just about getting the stool sample into suspension. Now, you might be thinking, well, if it's just into suspension, why do you not just get runny sort of diarrhea type stools? Well, the reason we don't do that, and we have cutoffs relating to something called the Bristol stool score or the Bristol stool chart. And the cutoffs really relate to, is this person potentially constipated or does this person have diarrhea? And we wouldn't accept either, because constipation and diarrhea can be proxies for infections or problems within the gut that might make the microorganisms essentially unsafe in the context of FMT. So historically, it used to just be about creating a suspension. What we now try and do is try and remove the non-microbial components, so basically fibers, from the stool sample, and try to basically distill down to the microorganisms only. Stool is actually quite a complicated substance. That includes undigested foods, a variety of microorganisms, bacteria, virus, fungi, and small viruses that infect bacteria called bacteriophage, as well as other components that you may have ingested. For example, in smokers, sometimes you can find ash in stools, and things like mucus and antibodies, colonocytes, which are elements of the inner lining of the intestine, so on and so on. So the purpose of the processing is to try and distill down, or maybe distill is the wrong word, but what we're trying to do is remove the microbes and the microbial elements from the non-microbial elements, because it's the microbial elements that we're most particularly interested in the context of FMT, because we're trying to change the recipient's microbiome. So how do we do that? We do a series of processing steps under typically controlled conditions. We want to, as best as possible, replicate the intestinal environment, which is anaerobic, so oxygen-free. And interestingly, we want to protect the microorganisms that have been donated as much as possible and keep them alive, which is very different to a traditional pharmaceutical manufacturing process, where you don't want there to be any bacteria in there at all. Sometimes you want it to be completely sterile, if you're injecting it, for example, in someone's vein. So what we want to do is not only keep the microorganisms alive, but we also want to make sure that no microorganisms from the environment can enter into the sample. So it's quite complicated and quite challenging. The suspension of microorganisms then goes through subsequent processing steps, and typically these days is either stored frozen as a suspension or is taken through some sort of drying process where the aqueous component is removed and we produced a powder. Historically, and it doesn't really happen so much anymore, processing would happen essentially on the day of donation, and recipients would get the FMT the same day. And that's typically described as being fresh versus frozen. I'm not so keen on the fresh nomenclature, but you kind of get the picture. It's done on the day and it's not stored, frozen or banked. Earlier on in the field of FMT, we did a lot more on the day type processing rather than storing anything and then giving it at a later date. So instead of creating a bank or an inventory of processed material that could be administered, it was typically done on the day. And that's because no one had really compared to see if a frozen sample is less effective or more effective than a fresh. And typically what was seen in the scientific literature and research was that frozen was pretty much as good as fresh in the context of C. difficile infection or prevention of recurrence of C. difficile infection. So based on that, people started to do frozen a lot more, and we started to move away from relatives to anonymous type donors. And there's also benefits associated with anonymous donors as well. What happens after we've managed to distill the microorganisms and either produced a frozen suspension or produced a powder? Well, typically the powder is encapsulated, and FMT as a procedure is associated with a number of medical procedures, like a colonoscopy, which is a tube that goes up the back passage, like a nasogastric, nasoduodenal, so first part of the small intestine, or nasojejunal, middle part of the small intestine tubes, which go up the nose, through the stomach, and into these parts of the intestine. And the microorganisms are essentially pushed into the patient through these tubes, and they arrive at some point in the intestinal tract. Now, if it's going up the back passage, it's going into the colon, so the large bowel. If it's going from top to bottom, it typically goes into the bottom part of the stomach or to the small intestine. And there's been a variety of research over the last 10 years comparing upper GI delivery versus lower GI delivery, what's more effective, what's less effective, so on and so on. Typically, the evolution has been from enema or nasoduodenal through to capsule, which is typically what we're doing now. Some clinicians prefer colonoscopy because you can also visualize the colon at the same time, and that's quite useful in things like C. difficile infection or colitis, where visualizing the inner aspect of the colon gives you an indication about how severe the patient's condition, disease, infection actually is. So I've mentioned C. difficile a lot. That's the most established use case. Interestingly, in terms of history, I think that the first recorded case of FMT in modern medicine, which was published in 1958 by a gentleman called Mr. Ben Eisman, the chief surgeon at Denver General Hospital, he administered FMT probably for patients suffering from C. diff, although it wasn't really known as C. diff at the time. And there was a little bit in the literature following on from that in patients with ulcerative colitis, but we didn't really see that much FMT until 2013, when there was a landmark randomized controlled clinical trial, the gold standard of medical evidence, which essentially showed that FMT plus antibiotics in these patients who had an overgrowth of C. difficile, a nasty hospital-acquired bug, typically a hospital-acquired bug, did much better than patients who just received antibiotics alone. And it kind of broke the cycle of patients who were getting recurrence. So what was happening with these patients is there were too many bad bugs in the case of C. difficile, too little good bugs. So there was like too many weeds in the garden. Those bad bugs were producing toxins. The toxins were inducing inflammation. Sometimes the patients were going on to die. And if they were treated with antibiotics, they got the FMT after, which replenished the garden with all the healthy plants, and as a result, the weeds couldn't grow and kind of outcompete and take up all those biological niches. So that trial spurred a huge wave of interest in FMT. It catalyzed lots of funding, company formation. And since then, we've seen hundreds of clinical trials, hundreds of publications, and many companies and patents filed following on from that. Okay, so why would somebody need an FMT? Why would someone benefit from an FMT? Why is it done really for anything? So each of us has something called a microbiome, term used to describe communities of microorganisms, their collective genomic potential, so all of their genes, and their theatre of functional activity. And essentially, what we now know is that changes to the microbiome in terms of composition and function are associated with, likely contribute to, and in some cases are probably the cause of, development of disease, some of which are really underserved in terms of treatment options. So the theory, the thinking, is that in patients with microbiome perturbance, so change, and disease linked to changes to the microbiome, if we can change their microbiome back to a healthy state, then we might be able to alleviate symptoms and ideally cure the disease, which is currently incurable based on currently available medical therapies. And there's a variety of different ways we can change our microbiome. But FMT represents one such avenue that is quite dramatic. We're taking something, communities from a healthy person or from someone before they've had a disease or a change, in the case of autologous FMT, and giving it back to them. So it's a rapid, sudden change to their microbiome, reversion hopefully back to something that's healthy. The human colon is an incredibly efficient fermenter system.